would not be able to succeed in this country competing with the federal government. No insurance company, no private insurance company that offered a health care product could win and succeed against the federal government if they were not only competing, but they were also setting the rules. They were on the playing field, but they were also the referee. And that's a real problem with this situation with a public plan, a government default plan. And I'm sure my colleagues have talked about that in the time that I had to be away from the panel. But that's you may want to comment on that. But you know, regarding your patient Shirley Healy, you made that anecdote and talked about her and the need for that stent and what she went through because of what I would like to call, and I think you described as rationing. When we had our first markup in Energy and Commerce the other night in regard to H.R. 3200, the America's Affordable Health Choices Act of 2009, I asked the chairman and I asked my colleagues if they were as concerned as I was about the possibility of the government making medical decisions and literally with all this comparative effectiveness research council taking the decision making out of the hands of the physician, taking the art, not just the science, but the art away from the practitioner of that art. And so what I want to ask you is, if we go to this system as those 1,100 pages now describe, without some significant changes, and that becomes law in this country, what do you see for your business in regard to trying to get them access to care and out of that long queue and not be rationed out of the healthcare system?
Well, there are other countries who offer health care. It isn't a week that goes by I'm not contacted by hospitals in India and Pakistan and Bangladesh and Philippines and Thailand. I don't want to be sending my clients offshore. There are risks inherent in traveling to these countries. I won't get into that. I have faith, however, and I hope it's not misplaced, that while we Canadians tend to go to the end of the line willingly, patiently, and without grumbling, I don't see Americans doing that. I have a higher regard for the American resistance to being pushed around, and I remain confident that there's going to be a way, if people want timely delivery of health care, that one way or the other they will work out a way to deal with the doctors. I don't know if that's correct, but I would like to think the American spirit is more or less willing to roll over and play dead as Canadians do.
Let me just reclaim my time, because I know we're getting short of time, and the chairman has just given me the signal. But I think the answer is, if I could just expound on your answer a little bit, that you certainly won't be able to send them to the United States anymore, because if we adopt this system, the same kind of problems that they're trying to get away from, they will inherit when they get to our shores. So,
I agree with that.
Mr. Chairman, thank you for your patience. I yield back, and if we have a second round, Ms. Kerrigan, I have a small business question for you.
Thank you, Doctor. Mr. Herger.
Thank you, Mr. Chairman, and thank you for your line of questioning, Dr. Gingrey. We appreciated that. I'd like to ask a question of Ms. Kerrigan. We know that there is a massive cost shift between government entitlement programs like Medicare and Medicaid and private insurance plans. Private insurance plans essentially subsidize the underpayments of government programs, and according to a study by the actuarial firm Milliman, this cost shift results in people with private insurance paying an average of $1,788 more out of pocket every year. Do you think this would change under the government plan option proposed by the House bill? And wouldn't the government plan simply place further pressure on private insurance and employers, leading to even more and more people dropping employer coverage to select the government plan?
In short, yes. With respect to the government option, the government is going to set the rules of the game. Certainly, they'll have a competitive advantage. They'll give themselves a regulatory advantage. And it will crowd out private insurance. There'll be fewer choices. More insurance companies will leave the market. And more individuals will end up in the government plan. Again, if some government sets the rules of the game, the competitive game, it's going to be to their advantage. And what that means is that there's going to be fewer insurers and more people going into the government option.
I share your concern. I share your appraisal of what I see happening. And it's not like we don't know how the government plan will be run. We see examples. We've just heard from Mr. Baker, what is taking place up in Canada. We also have similar stories from the UK and Europe. And Ms. Holmes, I know that you have similar concerns. So I thank you. And the good news is that the American public, the American people, and American voters are becoming more and more aware, and as they are, of what is being overnight in these 1,100-page document health care plans that no one's able to read, and we don't even have a final price tag on before we're voting on them. The more that are becoming aware, the more and more concern they're having. So thank you very much for participating. I yield back.
Mr. Camp.
Well, thank you, Mr. Chairman, and I want to thank you all for being here and for your comments. My concern is obviously how chilling the testimony, Mr. Baker, was about waiting lists and the effect on people and their health. And my question is really about the kind of innovation that is necessary to continue to deliver the highest quality care to patients. And if Dr. Sikora is still listening, I'd like to hear his comment. I'd like to hear your comment as well. How do you see in the UK, and then maybe we'll go to Mr. Baker in Canada, the ability to use new procedures, to try new cancer therapies, for example? Obviously, those are often more expensive because they're new and they're untested. How do you see a national plan affecting the ability of physicians to be able to try these new treatment techniques, use the higher cost, particularly with regard to cancer, and comparing the survival rates of cancer between the UK and the US? If you could comment, please.
Sure. I mean, there's been some very good comparisons of drug use across European countries that were collated and published just after in January of this year. And it's very clear that because of the way in which we bureaucratize whether a drug will become available to a cancer patient through NICE, sort of rationing organization in a way, health technology assessment, we're falling way behind over the last 3 years our European colleagues on the mainland. And that means that over time, cancer survival, which was already low in Britain, will drop considerably compared to the rest of Europe. I think that the real issue is how you can get things moving. And I think doctors, my generation of doctors, have felt their control over the destiny of patients, and indeed their own destiny, has gone down as the system's got far more concerned with looking in at costs, trying to rationalize costs, trying to make comparisons. And that's one of the problems. It's individual freedom disappears in there, and that causes a lot of concern. Now, the other problem that you end up with, and certainly I can see you have it in Canada, regional variation. So, and even on a very small scale, so one patient living on one side of the street may go down a referral path that will allow them access to certain drugs and certain expensive, innovative treatments. On the other side of the street, they may go down a different route and not get them. And that's really a problem, that then a sort of geographical inequity comes into it. So, the problem with government systems, I think, is the lack of any incentive to move forward, to embrace innovation, which is one thing your country has really done in health technology.
Thank you very much, Mr. Baker. Your comment on not only just being able to get treatment, but the quality of treatment with using the ability to use innovation to really find new ways to cure disease.
Well, I'll tell you a story that I found chilling. I got a call from a gentleman in Newfoundland, one of our poorer provinces. His father has a blood condition. He really needs a bone marrow transplant. This is impossible in Newfoundland. It's impossible in many parts of Canada, but this is what would save his life. Alternatively, he's having weekly blood transfusions, and he's been doing this for going on a year. The doctors recently told his son, you know, we're going to have to stop these transfusions. And he said, well, wouldn't my father die? And they said, yes, he ultimately will. And they said, why are you stopping it? Well, we can't keep giving him transfusions forever. And we don't have the money to pay for him to leave the jurisdiction to go to Boston, for instance, to have the bone marrow transplant. System in Canada, and it will happen here too, the people who deliver health care become hardened. They become immune to these sympathetic stories that normally you and I would feel so sorry for people. They're hardened to it, and they have learned just to tell people, no, it's not available, you cannot have it, move on to the next person. And I haven't been able to do that in my own business, but fortunately haven't had to because I do have this access to the U.S.
I was surprised to find out that the medicines that might be available to you depend on your zip code, where you live. Did I understand that correctly?
That's correct. Each province has its own Ministry of Health. They have their own budget. They have their own taxes that contribute to these budgets. If the budget is gone and there's no more money, the only way is to cut off access to more expensive procedures.
Ms. Brown.
Thank you very much. Dr. Sikora, just last year I lost my husband to pancreatic cancer, so I became very much involved in cancer treatment. And how many, I know you have an independent cancer facility. How many cancer facilities are there in Great Britain?
Sure. Altogether, there are 61 cancer centres in the UK, all of them within the NHS. We're just creating an independent system now, and to provide radiotherapy and chemotherapy. And what's been happening in the NHS, I mean, I think, as I said in my statement, that the Conservatives, the generation before a decade ago, wanted to get competition between the independent sector and the NHS, and Labour the same. They really pushed through under Tony Blair a very competitive way forward, which is resisted by the workforce and by other politicians to drive value out of the service. Now it's sort of half and half, and I suspect whatever happens in our next election will determine whether we get choice and competition or whether we have more of the same. And I think it's very difficult because the British public love the NHS, and they've got a lot of reason to. It does deliver, to many, very good care. The difficulty is it just finds it very difficult to embrace innovation. And cancer care, sadly, pancreatic cancer, there's not been much new over the last decade, but the speediness of getting the diagnosis, the speediness in which you start treatment really allays a lot of psychological problems that cancer patients have. You can get on with it if you know what's going to happen. Mm-hmm. And we still have quite great delays in diagnosis because of lack of imaging capacity and lack of histopathology to make diagnoses.
Let me ask you a follow-up question, Doctor. There was a study that was done in Brussels, and I brought this to the attention of an oncologist, and he made sure that my husband got the necessary combination of drugs. It was too late for him. But if a patient comes to you having discovered a formulary that works, that has been proven through clinical trials, are you free, if you were in the NHS, would you be free to use this system, this protocol?
Not unless NICE have approved it, or I can get special exemption from the primary care trust. They're the payers of care. Now, Canada is done on provinces, as we've heard here, a much smaller country, obviously. We have 152 PCTs that make decisions. Now, obviously they're going to come to different decisions, and that's the basic